Hello, everyone, and good day to you. I'm Dr. Christosik, and I'm excited tonight about our episode here on the other side of medicine. And many of you who listen to the podcast know that this podcast is all about natural medicine, functional medicine, but at the same time, on this program, we understand and respect conventional medicine, and we understand that there's a place and a time for all these things, especially when it comes to emergency medicine. And so tonight we have a very special guest on the program. We're going to be talking about epilepsy, and we're going to be talking about neurodegenerative diseases. And he's a neurologist, and a very famous neurologist, and is a board certified neurologist. His name is Dr. Sharlin. And let me go ahead and remove that. Anyways, this is live, so I'm going to go ahead and put my my phone here on. Okay, there we go. So he's a neurologist, and he's a researcher. He's a teacher, and he's an author and speaker as well. And in the landscape of neurological care, through functional medicine as well as regenerative strategies and advanced diagnostics and emerging treatments that go beyond symptom management to achieve a true reversal of disease, and that's what he's all about. You know, with over 25 years of experience in neurology, Dr. Sharlin, he's integrated conventional neurology, functional medicine, and cutting-edge regenerative medicine to provide people with therapies, patient-centered approach to conditions like Alzheimer's, multiple sclerosis, Parkinson's disease, epilepsy, ALS, chronic migraines, and his work it's informed by a deep commitment to science-based medicine, to evidence-based medicine, which I really applaud. And he's pioneered in neurology and the reversal of degenerative diseases. And he's a leading proponent of the idea that neurological diseases are able to be reversed. Traditional medicine oftentimes tells people that they're not able to reverse these degenerative diseases, but he has found with his experience and his expertise that these neurodegenerative diseases are very reversible many times. And according to the patient's cooperation with his approach, he's seen some pretty amazing things, and he's actually written a groundbreaking article called The Reversal of Cognitive Decline of 100 Patients. And that was actually reported in the Journal of Alzheimer's and Parkinson's back in 2018. And Dr. Sharlin provides a compelling evidence with his experience that cognitive impairment and early Alzheimer's disease can be improved and even reversed. So he really using personalized medicine and multifaceted interventions. So without further ado, I'd like to welcome Dr. Sharlin to the other side of medicine. Welcome.
Thank you. Appreciate it. Thank you for having me.
Well, you know, Dr. Sharlin, I have to say there is a bit of a selfish motive for having you here this evening as my guest, because I recently had an epileptic seizure, which caused me to have an accident, and it could have been life-threatening to not only myself, to people that I was surrounded by on the freeway. So this has, as I said, a little bit of a selfish motivation for having you on tonight. However, I really look forward to trying to help other people who are suffering with epilepsy and to help them to get some really good advice, practical advice, and really some good advice from integrative professional like yourself on how to approach this condition with some really good evidence-based medicine that's going to make sense for the individual who is suffering with this condition. So I'd like to see your perspective on what is epilepsy, and from your perspective, how do we approach it?
Yes, thank you. Well, I think that's a great place to start. What is epilepsy? And it's important to understand that seizures, a seizure, and having epilepsy do overlap, but they are not, in fact, the same thing. And the most distilled out, simplified definition of what is epilepsy, the answer would be, well, it's a condition in which the individual who is affected has had more than one seizure. So in other words, having a single lifetime seizure does not make a person epileptic. They have to have had more than one seizure. That is the most important defining principle because, I saw a patient earlier this week as an example who had had a single lifetime seizure a couple of years back, went to an emergency room. I'm still waiting on the records to really understand the thinking that the doctors were using at the time that they saw this young man. They decided to put him on an anti-epileptic or anti-seizure medicine. Now, in standards of care, that doesn't make sense to me. In general, we don't put people on anti-epileptic drugs who have had a single lifetime seizure. I would, and if I been in the emergency room or had I seen him shortly thereafter as a consultant in neurology, would have done an evaluation, of course, including some blood work, brain imaging, electroencephalogram or EEG for short, which is the gold standard in looking into epileptic seizures. There may be some exceptions in which I might say, under normal circumstances, I wouldn't start you on a drug, but the reason that you had a seizure is so compelling and so concerning that I feel that the risk of having yet another seizure is very high, that I want you to be on a drug for now. But by and large, as long as the evaluation didn't turn up anything that was highly concerning, maybe a brain tumor or something like that, I would not have initiated a drug until the person clearly had a second seizure.
Mhm. Well, it's interesting that I wasn't aware of this, but I found out after I had an experience. I'm very, very physical, and I'm 76, and I do triathlons, and I play full court basketball with college students, and I work out with weights, and I swim. I mean, I'm just really active. And I did something that I think that was not wise because, we have limitations that matter. We're not invincible. I'm not 20 years old anymore. And I was doing high intensity interval training, which I'm sure you're very familiar with.
Mhm.
And I was on a treadmill doing 30 seconds of really high intense treadmill activity. And I was doing like 9 sets of that. And I did it for about 6 months. And after about 6.5 months, I got off the treadmill one day and it's like the world just like spinning all over the place. And I thought to myself, did I just have a TIA? And sure enough, I didn't realize that because I didn't check it out. But about 3 months later, I had my first seizure. And they said, we have found on CAT scan that you had a stroke. You've had a couple of mini strokes. And I go, oh, so it confirmed what I thought.
Mm.
With strokes, you could have epileptic seizures that follow. So I wanted to get your perspective on that as well and how common that is.
It is common, fairly common, and I think that also points to something, a bigger picture, that a seizure is really a symptom in some respects, right? There are many reasons that people have seizures. There are many different seizure types. And if I may say, in an older adult such as yourself versus a child, the reasons that a person might have a seizure would be very, very different, right? And we certainly do worry in an older adult because there are many diseases we associate with aging, that something much more serious is going on, such as a stroke that has left a scar on the brain, a tumor, a blood clot of some kind. Maybe somebody has maybe hit their head very hard and had something called a subdural hematoma and walking around with something irritating their brain surface. There's usually something going on in the older adult. It is not uncommon if we look across all ages with the different epilepsies. First of all, there's something called a bimodal distribution, meaning that by and large, new onset seizures occur in young people, and that can be anywhere from infancy and childhood and teen years. And then by about age, mid 20s, 30, it's sort of the curve flattens out. We don't see new onset seizures and 40-year-olds. There are exceptions, but if the 40-year-old shows up, never had a seizure before, you have to be concerned. First of all, it might not even be a seizure. It's another discussion we can have. But then when you start to hit that, 60, 65, 70, 80, then you have another peak of, more common presentations of epilepsies. And in the younger folks, it can be genetic causes, brain malformations, subtle changes in brain structure, something called mesial temporal sclerosis, very common in temporal lobe epilepsies, genetic reasons, if I didn't mention that, even mitochondrial disorders. And then again, in the older adults, more commonly, what we would call symptomatic epilepsy, meaning that the seizure is a symptom of something else. So that right there is very important to understand. And then there are many different seizure types, but broadly, there are seizures that will start in one area of the brain, and that seizure may spread to a larger area, even the whole brain. And then there are seizures that seem to, at least on the surface EEG, start all around the brain, all over the brain, all at once. We call that a primary generalized seizure. And since a seizure is a behavior in effect, it's an involuntary behavior. It's the presentation, what you see outwardly if you're witnessing someone, really may be a manifestation of the part of the brain that's affected by the seizure. And when I was at Vanderbilt University many years ago, as a neurology resident, the chief of epilepsy, who's still there, would do a lecture every year with the residents in which he would show videos of people having seizures. And then he would stop the video and he would say, "Is that a seizure?" And some of them looked very obviously like what you would expect a seizure to look like, the tensing up of the body and then the jerking and maybe a little bluish around the lips and, gurgling noises and that sort of thing. And some of them might be very odd and interesting, like the person gets up, walks around in a circle, claps their hands, sits down, and you're like, that's not a seizure. And in fact, it is. And then the person you thought was having a seizure, the one who tensed up and jerked and all that, it didn't turn out to be a seizure. So you can't always tell by looking. But the point I'm making is that seizures are really diverse and varied. Certain things in common, that they are behavior, that they are a result of a synchronized discharge of nerve cells from the surface of the brain, that they're generally self-limited, although there are seizures that can be all seizures are serious, but some can be more serious than others in the sense that the seizure may not stop, or there may be a clustering of seizures with no clearing in between. We call this status epilepticus, and this has about an 80% mortality. And so it's very, very, very serious. Those are medical emergencies. There may be seizures where the person doesn't seem to be doing anything at all. They may be just sitting there. There may be a brief alteration of awareness, a fluttering of the eyelids. But if there are wires on the scalp, the EEG is hooked up, you'll see big, generalized, what we call spike and wave discharges. That person was having a seizure. So we shouldn't certainly judge the seizure by what we're purely observing, because it is defined in part by what is seen on the EEG, not just by the naked eye. But again, that person, we want to strive to understand, why did this seizure occur, and determine if it is appropriate to treat that person with medication.
How common is it for seizures to follow a TIA or even a major stroke?
Well, the main part of the when a stroke results in a seizure, it's usually what we call a cortical stroke. I think of the brain like, most folks have at least seen on the internet or somewhere, a CAT scan or an MRI image. And these are, we use the term slices, brain slices, as they take many images. And if you might think of a piece of white bread, and I don't recommend eating white bread, I'm just using it as an analogy, but there's the crust, right? And then there's the center part of the bread that's white. And in fact, in the brain, the analogy is that the outer layer is called the gray matter of the brain. And then that inner surface, the white part of the bread, is called the white matter of the brain. And usually when a stroke results in a seizure, it's because that cortical or gray matter surface has been injured, and there may be an area of scar tissue, and that becomes sort of an irritant, an electrical irritant on the brain. And in fact, I mentioned this entity called status epilepticus, in which a seizure doesn't stop, and there's a very, very high mortality rate. If we look at individuals who are more likely to go into status epilepticus, one of those populations would be older adults with a prior history of stroke.
Mm-hmm. Interesting. So let's talk about how functional medicine physician like yourself would approach somebody who has epilepsy. I know that you have to do definitely a bunch of diagnostic workup, but there are some things that would apply, as we've talked about prior to getting on the podcast, that would be applicable to any kind of chronic disease that need to be looked at and cared for with any kind of chronic disease. So what are some of the things that you would look at and approach for with somebody who's experiencing seizures?
So I developed a framework that's really applicable across the board to integrating conventional or traditional neurology with the principles of functional and regenerative medicine. And we call it a 5-pillar approach. So if you were coming to me as a brand new patient, and we call it in medicine the chief complaint, what brought you in, and you say, well, I had a seizure and I was told I needed to see a neurologist. The first thing I'm going to do is simply take a medical history, a good, thorough medical history, and we call that our identify pillar. As I mentioned, not all things that look like seizures are in fact seizures. So I want to know, is this a seizure? Is this a seizure? And if you've had more than one event, do you have epilepsy? So I'm going to start with the very basics of maybe some blood work that you would get pretty much anywhere in, any good clinic, looking at electrolytes and complete blood count, things like that. Of particular interest might be your sodium, calcium, magnesium levels, so forth, because alterations in these electrolytes and minerals can lower the seizure threshold. I'm going to take a family history. Any family history?
Before you move on to the family history, when you mentioned the blood work, when you go to get standard care, there are some tests in functional medicine, that are used often in standard medicine as well, that look for, levels of inflammation, things like insulin resistance, that things like oxidative stress. Do you incorporate some of those things as well in your workup for the blood work?
So yes and no. And the answer is, we have to know what's going on first. And certainly the principles that underlie functional medicine of inflammation, oxidative stress, toxin exposure, gut dysbiosis, things like that are important. But they come around when we start to investigate those root causes. I mentioned before we started the podcast that I use the analogy of quantum physics. Does the tree that falls in the forest make a sound if no one's there to hear it, sort of thing? Or Schrodinger's cat, the cat in the box. And the reason I bring this up is that while we like to talk about disease reversal, and I certainly have, several cases, individuals I've worked with who've demonstrated now by biomarker analysis that at least for the moment in time, their disease has reversed. It's important that, to me, functional and regenerative medicine are part of the toolbox, but traditional neurology is also an important part of the toolbox. And we have to both understand the disease itself that the person is dealing with, the natural history of that disease, if you will, as well as the person who has that disorder and their unique biochemical and cellular makeup.
So initially you would just do some of the standard tests, and then you reserve some of the functional tests for other levels.
Right. That would be the next level.
Got it. Okay.
Identifying the problem correctly. And it's important to understand there's a classic set of papers published in the medical literature among a neurologist and epileptologist. It's called the Kwan and Brody papers, KWAN, and Brody, I believe, is BRODIE. These are two leading epilepsy researchers who have repeated the same study at least a few times over the years. And they asked a very basic but important question, which is, if you have new onset seizures, if you have a brand new patient you're seeing, never been treated, and you start them on a drug, what is the likelihood those individuals will have 100% control of their seizures? So why don't you, I'm just curious, if you're not familiar with Kwan and Brody, take a stab at what do you think the answer to that question is? All comers, all drugs. Doesn't matter. Take it.
I don't have the slightest idea.
Well, the answer is that, and what's interesting is these researchers did the same study over, several times in the last 20 years, and they came up with the same results. And the reason it's interesting, but it's also important, is that in 20 years' time or 25 years' time, there have been many, many new anti-seizure medicines that have come on the market, and yet we've not really improved the statistics of control of epileptic seizures. So it goes like this. You start a person on one drug, kind of like pick a card, any card, pick a drug, any drug. There's about 50% of people who are newly treated for their seizures will have complete control of seizures on the first drug that's chosen. Well, that of course means that 50% will not. So now you're faced with trying another drug, and unfortunately you only increase your odds by about 10%. So now you're up to 60% that are 100% controlled, 40% are not. So now you go, well, what else am I going to do? Well, I'll add a second drug. I'll use two different drugs, have two different mechanisms. So maybe I'm attacking the problem from two angles. And in fact, you reach a point where more drugs is not more control, it's just more drugs. And the bottom line is about a third of all people with epilepsy will continue to have seizures to some degree despite medication. Mm-hmm. So, there are many compelling reasons to utilize functional medicine principles, but I think you and I would probably both agree that if you're among the group that still has seizures despite medicines, this is very disruptive and potentially fatal. And there's very good reasons to think outside the box, like, what else can I do? Mm-hmm. What else can I do to improve my seizure control? And I think in this context of epilepsy, that third of individuals are going to be among the folks who are most motivated to do something. Mm-hmm. After all, if you take a drug and it works for you and you can go about your life, you may or may not be all that motivated, and functional medicine takes a lot of motivation, to do anything different. You can have your life back, take your medicine, you're good, go on, become a famous chiropractor. Where's your pain point, right? I don't like taking the drug. It has side effects. It might hurt my liver. And that makes sense. I get that. But usually when we make decisions as human beings, we're in a little bit of pain, emotional, mentally, or physically, that drives us to the point where we're willing to make a change, right?
What are the side effects, and how safe are these drugs, or are they not safe? I mean, I'm just curious. I don't know very much about the epileptic drugs that are used.
There have been quite a few drugs that have come out over the last 40 or so years. I started my neurology residency at the University of Virginia in 1993, and at the time there was a little facility called the Blue Ridge Hospital. It was an epilepsy inpatient unit, some very, very sick, large, for the most part, children. These are people that have 50, 60, 70, 80 seizures in a day. And there was a drug called Felbitol that came out that year that was really the first of a generation of many, many drugs that was to follow Felbitol. And because we were sort of in the paradigm of either took Depakote, Dilantin, or phenobarbital, or maybe Tegretol, this is about all the drugs we ever used, it was very exciting to have Felbitol. Well, the interesting thing was we spent the first 6 months or so of that year of residency putting all these very brittle epileptic kids on Felbitol, and then the next 6 months taking them off the drug, because despite the fact that it was FDA approved, when people were treated a little bit longer beyond the duration of the clinical trial that allowed that drug to come to market, they developed liver failure. And so we do have to reckon it's not all epileptic drugs are toxic to the liver, but many can have that risk, and it is something to monitor. But for the most part, there are common side effects such as dizziness, difficulty, say, walking a straight line, almost like a person is intoxicated, as we call these side effects toxicity side effects. And those can usually be avoided by starting on a low dose and building someone up gradually. There are, on an individual basis, side effects that can be observed. A very commonly used drug today is called levetiracetam or Keppra. And some people who take Keppra can develop kind of an emotional agitation or irritability that's very problematic for them, and they need to come off the medication.
So what if there are these side effects in your experience? Does some of the remedies in functional medicine negate some of those side effects? I'm just curious. I was just thinking in terms of, if you mentioned liver toxicity, we know that milk thistle, the herb, is a very powerful antioxidant and liver detoxification herbal formula that really works really well. I mean, I know that there's this one study that people were given a mushroom that causes death to rats, and they would give the mushroom to the rats, and they would literally, if they gave the mushroom to them without anything, they would die within like 10 or 20 seconds. But they gave these rats these mushrooms, and after that, they gave them immediately some of the milk thistle in tincture form, and the rats didn't die. So what is your experience with integrating some of those things simultaneously to help negate some of the side effects?
It makes perfect sense to me what you're saying, and I will say that I haven't necessarily done that with my patients who have epilepsy, but the broader concept is extremely important, that you can take 50 people and put them on the same medicine, and some people have side effects, some people don't, or some people have success with their seizures and some don't, and yet it's the same drugs, the same mechanism. Why is that? And I would draw the analogy to the peak of the COVID epidemic, when we had very little treatment, and tragically, we lost 1 million Americans to this disease. And when some of the epidemiologists analyzed, deaths from COVID early on, it was very clear that there were a handful of risk factors that help predict who are our most vulnerable population. And outside of aging, which I'm sure you would probably agree, I mean, we're all aging, but in some respect, age is also sort of a catch-all for all the stuff, right, of our lives, all the inflammation and the oxidative stress, all the things that happen. But on the other hand, besides aging, diabetes, obesity, low vitamin D. Why? Because low vitamin D tends to allow for an immune system that really can't reel itself in, right? We need an immune response, but we don't need an overly aggressive immune response. So something as simple as optimizing vitamin D levels has been shown to mitigate many diseases that we deal with, whether that's COVID or whether that's, multiple sclerosis or Alzheimer's disease. So I certainly agree that we need to be thinking at that root cause level as to what is it about that person and what can they do, whether they're taking milk thistle to protect their liver, or even more broadly, how does diet, for example, affect the likelihood of seizure control? And of course, it can have a very profound effect.
Sure. Okay, now I want to just shift to something that I really want to make sure we are able to address this next topic, which I think may have some intersection with what we're talking about right now with epilepsy, but I think it has a broader context with the things that you treat on a regular basis, the Alzheimer's and the Parkinson's and the ALS. So are you familiar with the work with the newest discovery with the lymphatic system of the brain?
Well, if you're referring to the so-called glymphatic system, and it was first described maybe slightly less than a decade ago, and we know that it's most active when we're asleep, and it's an important part of how our brains work. So absolutely familiar with it. I had some fascinating data. I saw an article that was published, and was not the first time this has been looked at, but sleep deprivation, for example, and otherwise healthy young adults will transiently allow for the accumulation of a protein called amyloid beta in the brain that we associate with the development of Alzheimer's disease. And then when, these are controlled situations, maybe they're done in like a psychology experiment or something like that. They look at, do PET scans on the brain, that's positron emission tomography. And then when those individuals are allowed to sleep, they repeat the PET scan, all that amyloid that accumulated has now been allowed to solubilize and leaves the brain and is cleared from the body through the lymphatic system.
Yeah, what's really interesting is that they've discovered that there are other proteins besides amyloid protein that are released, that these toxic proteins in their different types in like ALS, for example, or Parkinson's. But the concept still is that these toxic elements accumulate, and if the lymphatic system, the lymphatic system inside the brain is able to clear this out, then the individual will improve dramatically.
The simple take-home message is sleep. Get your sleep, right?
Oh, no doubt, no doubt. As you said, during sleep, the brain washes away the toxic elements through this lymphatic system, which is pretty amazing. Could you explain in simplistic terms for our audience? Because this is just a recent discovery. By the way, this is interesting, Dr. Sharlin. I just met a gentleman who you probably already have heard of. He's a microsurgeon. His name is Dr. Wei Chen. Have you heard of him?
I haven't. No.
Okay, so he's a world-renowned microsurgeon. He's actually a plastic surgeon, but him and his colleague discovered the meningeal, the covering of the brain lymphatics that are in there in the meninges, and so I was sharing this knowledge, which I didn't have any knowledge about, to be honest with you, prior to a couple days ago. I didn't have any cognizance of this at all. And I think there's a lot of doctors from all disciplines who don't know about this, and you're certainly very wise to know it. But I spoke with a very dear friend who teaches at the medical school here in Northeast Ohio. And I had mentioned to him about the lymphatic system in the brain, and he teaches at the medical school, but wasn't aware of it. He was still under the mindset that the brain, okay, it gets rid of the toxins through the cerebral spinal fluid or through the immune system. And so he wasn't aware of that. So I'm sure there's a lot of doctors that are in high places even who are not aware of it. So I applaud you for really keeping me abreast on this stuff, because like I said, I didn't know about it myself. So could you explain to our audience, because this is so new that it's pretty revolutionary, the things that are going on with this?
To explain the lymphatic system itself.
Maybe in simplistic terms, or maybe you let me do it if I may.
Yeah, I mean, in general, one of the ways of looking at our biological existence is in the context of metabolism. Things come in and things go out. Your car combusts gasoline and, with air and a little spark, if you have a conventional, combustion engine, and that vehicle makes byproducts of the combustion of gasoline that then requires an exhaust system for the car. And that's, of course, released into the atmosphere, which, a whole other discussion. But the point is that we do too as human beings. So, of course, we are exposed to external toxins as well. We say the skin is our biggest organ, and many things can be absorbed through the skin, through the alimentary tract, contamination in the food that we eat, whether that happens to be chemicals, heavy metals, whether that happens to be, a result of gut permeability and the leakage of particles related to the protein coat over the E. coli, called lipopolysaccharides, or LPS. In the end, if it finds its way to the brain or internally in terms of normal cellular metabolism, there is, build it up and break it down, and build it up and break it down. And then how are we going to get rid of that? Well, the body has a system, just like a vehicle has a system, that is a natural detoxification system. There's sort of the 10,000-foot view that is the glymphatic system. And then there's, a little closer up view, or what are the mechanisms? I'm sure you talk about things like glutathione on your podcast and how important that can be, for example, to detoxification. But in the end, I think, the fundamentals, as I said a moment ago, of, it's interesting to learn about this, and we want to ultimately do things to support that process. And yes, you can probably support, you can certainly support detoxification through a variety of compounds, the glutathione I mentioned, methylation support, and so forth. But on the other hand, if we can focus on the fundamentals of getting 7 to 8 hours of high quality sleep every night, and we can, we have the ability today to easily track sleep through all of the smart devices out there, you're really coming a very, very long way to bringing the brain back into balance, into homeostasis, right? And clearing these toxins and restoring harmony and order. And with that, putting a dent in these complex chronic diseases, whether they be epileptic seizures or whether they be Alzheimer's or Parkinson's.
Yeah, it's really interesting when I spoke with this microsurgeon. What they're doing is they're working with, well, right now they're only doing animal studies in the United States, but in China they're actually doing it on human studies. And in China they go right directly to the humans. They don't They don't have the precautions that we have here in this country. But in any event, he was talking about how in their animal studies, and of course in parallel in these human studies in China, that the people in China who have this congestion, this toxic buildup in the brain, inside the brain cells, and it gets this all backup of all these toxins, they actually are able to do microsurgery and clear out these toxins. And they're finding people that have things like Alzheimer's and Parkinson's that are unresponsive, and they're not able to do daily functions on their own without help, and they're completely can't recognize anybody after the surgery of getting rid of these toxins through the meningeal lymphatic system, or through the cervical lymphatic system, that these people very quickly are responding within a couple days even, and they're able to be aware of people around them. And within like 6 months to a year, they're actually doing things on their own. And this is chronic Alzheimer's patients. So I thought, my goodness gracious, this is extraordinary. But then I thought and stopped, and I said to myself, okay, doing a surgery is great to help somebody who's gotten that far along and abused themselves so much over the years to get to that state. Wouldn't it be wonderful to teach people how to make sure that if they have that surgery and get their cognition back and get their daily activities back that they can do on their own, to then change their lifestyle so they don't accumulate these toxins again? So I think we need a blending of conventional and functional medicine to really make this thing a very, very robust program, if you see what I'm saying.
Well, sure. And actually, that type of that thought process that you're describing with this doctor has been explored in the past with multiple sclerosis. There was a researcher who developed a procedure, and I'll never forget his name because I grew up playing hockey and skating, and those of us who spent time on a rink know what a Zamboni is. And his name was Zamboni. But
I grew up ice skating rink with the Zamboni as well.
There you go, right? So I was a Rangers, fan, and Islanders more than at the Flyers. I grew up in central New Jersey.
Mm-hmm.
But at any rate, these folks were going into this, primarily a procedure done by an interventional radiologist, and it basically involved manual or mechanical dilatation of jugular veins. And on an anecdotal level, people say, well, I had this done, or I know somebody had this done, or I know 3 people, or I read on a in the internet on some Facebook group or whatever, and there were people who are definitely getting better. But unfortunately, when the procedure was studied in a larger scale clinical trial, Zamboni himself was unable to demonstrate that in a statistically significant number of cases that the procedure truly helped people and reversed multiple sclerosis, even though maybe a handful it seemed to, and the larger scale it didn't, which means that it doesn't mean that detoxification isn't critical, because it absolutely is. But it sort of reminds me of those papers that you see, and it's like the aha gotcha kind of papers that come out of very conservative allopathic journals that say, we gave vitamin E to people with Parkinson's and it didn't work, right?
Mm-hmm.
Therefore, don't take vitamin E. Well, you and I know that I wouldn't tell somebody that taking vitamin E is going to cure their Parkinson's, but if they're vitamin E deficient, they're sure going to have a hard time managing their Parkinson's, because the level of oxidative stress as a result would be overwhelming. So bringing things back into harmony and homeostasis by correcting nutrient levels, by supporting detoxification through the lymphatic system, I would say is the more important take-home message.
Mhm. So let's continue on with your 5-step approach. You've mentioned the first level, which I think our audience got. What continue on so we get the full measure of what you do in the 5-step procedure.
Right. So then we're going to get into investigate. The first pillar was identify, then investigate. And that's the part that people love. They get all the lab tests, and we have our brain tune-up protocol, in which we look at a number of different markers, something like 75 different markers. These fall into broad categories, including methylation, inflammation, oxidative stress, toxins, hormones, trace minerals, some genetics, etc. And so we can identify, along with a detailed timeline, basically your biography, a story of your birth, your growing up years, before you got sick, after you got sick, that tipping point, right? And piece together a narrative that helps us understand how is it you got here and what is keeping you on the trajectory. And that's, again, a combination of lab imbalances that are identified, as well as the narrative of your life itself.
Sure. Well, I'm sure that you would integrate into that for example, like a stool analysis. You could look at the microbiome and other inflammatory markers inside the gut. You mentioned, the lipopolysaccharides before. So people are not aware often, especially those who have been treated by conventional medicine, that they don't see the connection between the gut and the brain. But I'm certain that you approach that in your 75 tests. I'm sure that's part of it.
It is part of it, and certainly just about any disease that I help people with as a neurologist: Parkinson's, Alzheimer's, multiple sclerosis, ALS. There's a multitude of articles that have been published that have looked at changes in the gut, whether it be shifts in the microbiome, a preponderance of certain bacterial strains that appear to be more common in certain diseases, or even affect the expression of the disease, gut permeability issues, shifts in the microbiome so that some of those microbes are located in places they shouldn't really be, the small intestinal bacterial overgrowth and so forth. So there are, of course, a number of factors related to gut health. And from my perspective, tests for the most part are information. And I think importantly with stool testing, while we do sometimes identify, infections, parasites, things like that, or we might look at it and say, well, you're not ingesting enough insoluble fiber because your short chain fatty acid levels are very low, or perhaps you have high levels of an enzyme that suggests that, low levels of an enzyme that suggests you're not producing enough digestive enzymes in your gut, because normally this enzyme is very resilient and can pass through the digestive tract and be measured in the stool. But in the end, in the final analysis, stool testing really tells a story about who we are, right? And how did we get here? And to me, while fundamental to functional medicine is lifestyle, it's sleep, it's movement, it's nutrition, it's stress, it's human connection, and I would add in there environmental factors as well, that can be physical, mental, or emotional. How we think, how we feel are all important. Unless we're ready to engage in that narrative, then it's just purely information, and we're not going to do anything about it.
Sure.
I think.
What is the third facet of your protocol?
So the third facet really dovetails into exactly what I'm saying, which is how do you then go from identifying the problem, investigating the root causes, to putting the puzzle pieces together. And functional medicine then becomes a partnership with the patient. If you think about your traditional doctor, you go in and your blood pressure is high, and they say, well, I'm going to write you a prescription for some blood pressure medicine. Take this pill once a day. I'll see you in 6 months. If you have a problem, let me know how you're doing. that's not really engagement, right? It's an assignment. And it asks really very little of us other than to take a pill. And of course, it doesn't address the root causes of the disease. So how you bring people into the fold, how you connect with them in a heart-centered way, ultimately motivates folks to make the changes that are really critical and fundamental to me as to what functional medicine is. Because when they are willing to make those lifestyle changes, their condition can get dramatically better.
Wonderful. Then what is the fourth element?
The fourth, and I'll lump the fifth one in there together with it, are restore and regenerate. We sometimes in our clinic use the restore pillar in a more philosophical way. Some people will say, well, I just want to get back to the way I was, right? I want to get back to how I was before I got sick. But the reality is that how we were before we got sick is exactly why we got sick, right? So we really want to, help people to be a much better version of themselves. And you can look at that as restoration. I also, as a neurologist, somewhat unusually, have a very big commitment to hormone balancing, the use of bioidentical hormones for brain health, for overall physical health, not just in postmenopausal women, but in men as well. And in some cases, of course, in women who are still having menstrual cycles, who for a variety of reasons have disturbed their normal hormone biology and homeostasis. And hormones, we get too often are told, well, I'm done having babies. I don't need hormones anymore. Yeah, but you have a brain, you have a heart, you have muscles, you have bones. We know that women who get on hormone replacement therapy early and stay on that have a very dramatically reduced risk of neurodegenerative diseases, including Alzheimer's. So
Wow,
that
that's interesting. So would you, with a person, let's say, because we're talking about epilepsy tonight, would you say with a person who has epilepsy, whether it's female or male, that you would look at the hormones as well to make sure that you're doing a complete workup for them, so that it may be a risk that has an association with that imbalance?
I absolutely would. We've kind of focused in a way, without necessarily saying it, on things like testosterone, estradiol, and progesterone. And all of these have important anti-inflammatory, antioxidant effects. They're involved in growth and repair of tissue. Some of them are involved in memory and memory consolidation. Some of them support the release of neurotransmitters. But the other hormone that's extremely important, perhaps the most important from my perspective as a neurologist, is to understand the role of cortisol and stress and what I call the hypothalamic pituitary adrenal, thyroid gonadal axis, but certainly cortisol in general. We are here on Earth with sort of a mission, but our mission, first and foremost, to carry it out is dependent on survival. And so I use that analogy of, if I put you on a desert island and say, good luck, you're all by yourself. I tell my patients, you're not going to go and look for a nice beach to have a suntan. You're going to think, oh my gosh, I got to find food. I got to find water. I got to find shelter, right? That survival mode that we go into is really critical and fundamental, and is the most important role that our brains play for us, consciously or unconsciously, always monitoring data that received through the senses, determining if something is dangerous, and then taking action, again, consciously or unconsciously, all the way down to the level of systems biology, meaning our immune system, our mitochondria, what genes are turned on or turned off. And if we can bring harmony back, then these big bad diseases, including epilepsy, have a much better chance to be well controlled. And then, of course, not just symptomatically, but truly healing the brain.
So let's talk a little bit about your paper that you did in the Alzheimer's Journal. the 100 patients that were able to get cognitive skills back. Talk a little bit about that and what you discovered with that.
Yeah, that goes back to between 2016 and 2018. It was published in 2018. I had hung my shingle as a neurologist who integrated functional medicine principles into my practice in 2015. Before that, I was an employed neurologist, and I was still interested in it and trying to implement functional medicine principles. But I realized that by 2015, if I was going to do it the right way, I had to have my own practice. So I set out through the Institute for Functional Medicine to connect with the thought leaders that really were closest to me in my field as a neurologist. And one of them was Dr. Dale Bredesen, who's certainly hard at work today with his Bredesen protocol, RECODE protocol. But back then, he was out at the Novato Institute in California. He had, a couple of cases that he had, worked with people and seen some major changes. And I was fortunate to be in what he would call his beta group, his beta testing group, among a handful of people invited to Novato to learn about what he was doing. This was really before there was a formal computer program where you could enter data and all that. But he laid out his protocol for us. And I went back to Ozark, Missouri, where I live. And I, of course, had a copy of his first book. And I studied it and I thought about it and ultimately, applied those principles in my practice with great success. And because that's all I do in neurology. And, today there are 7 million people with Alzheimer's disease and probably many, many million more who have it but don't know it yet. It is a great opportunity to work with folks and to apply those principles and, observe what would happen. And in fact, we were seeing dramatic improvements in cognitive function.
Wow.
So I contributed, my team and I, about a third of those patients. There are other authors, but I was the largest single contributor to that 100 patients group.
Wonderful. That's wonderful. I would just, we're coming to an end here, and I just want to just get your perspective on the work that the surgeon that I ran into, the microsurgeon, and of course the other experts in the field, not only here in the United States but around the world, that are working with this microsurgery to clear out the lymphatic system in the brain. Are you encouraged by that? And do you see hope of working with those physicians who do that kind of work? And do you see it as a really valid way to help people? Or is it something that you feel is only an occasional benefit from that?
Well, I really do try very hard to stick with the science, and that science includes, principles that we've touched on, leaky gut and all that. Really, the whole adrenal fatigue that we call HPA axis dysfunction goes back to classical research by people like Cellier, who did his work at McGill University in Montreal, and I think really formed the foundation for how we understand chronic diseases today. And I would say that with Zamboni's paper, he, showed that, there may be individuals who benefit, but by and large, I don't want everyone running to China, wherever it is, to have this procedure thinking it's going to fix them. And I would say, by extension, while I'm very proud of the paper that we published with Dale Bredesen, the 100 patients, the difference today compared to 2018 when the paper was published, and Dr. Bredesen's doing the same, to be clear, he's in the same, sort of mindset that I am in regard to this, is we were seeing improvement in symptoms. We were seeing improvement in cognitive scores. He did have one case where he demonstrated with volumetric brain analysis that there was improvement in the volume of the region of the brain that is critical to memory, called the hippocampus. But by and large, we were seeing symptomatic improvement. The difference, fast forward today, is we are in the age of precision medicine and biological markers. And what's very exciting now is that we can understand the underlying mechanisms of why an individual gets sick. We can measure that through these biological markers. We can apply these functional medicine principles, and we can track these biological markers over time and not just show reversal of cognitive decline, but reversal, say, of Alzheimer's disease. And this has been reported. Not, I have cases, but Dean Ornish, a very well-known, sort of the patriarch, if you will.
He's actually been a guest on and I've interviewed him on my podcast in the past.
Fairly recently, within the last year, published a nice piece and used the same type of biomarker test we use in our office, and really a very basic, protocol, if you will, not nearly as sophisticated as most functional medicine doctors would use, but still importantly showed that if we focus in on that sleep, on an anti-inflammatory diet, on exercise and mindfulness, that we have the power to reverse these diseases that we've been told there is no cure, no treatment.
That's wonderful. Well, Dr. Sharlin, we've run out of time here. If somebody who has a chronic degenerative disease like Alzheimer's or ALS or Parkinson's, and they would like to explore the avenue that you take, how do they get in touch with you?
What I'd like them to do is go to our website, which is functionalmedicine.doctor. Instead of .com, it's just .doctor. Spend time on the website. If you want extra information, I have a YouTube channel. We've got a lot of videos there. I think it's really important. We do have an opportunity for a complimentary online consultation, phone call to get to know you better and make sure it's a good fit. But I think really importantly, before people sign up for a phone call, a consult, I want them to do a little self-education, a little what I call maybe pre-education, so that when we're connecting, they really understand what this is all about, and that they're ready for engagement. They're ready to jump in both feet and really work hard. Functional medicine.
I like that approach, and I really appreciate everything that you shared with us this evening. And I hope to have you possibly back in the future if you're willing. And I just want to thank you once again for your time. And I know that our audience is going to get a lot out of this. So is there anything you'd like to part with?
Folks, I would say the most important thing is that the fundamental driving principles of functional medicine are lifestyle. And for those who think that functional medicine is too expensive, it's outside of their budget, there's so many ways to engage. You can do so much to help yourself. And I'm sure that this podcast, the show in general, if you go back through all the episodes and listen to them and just start applying those principles a little bit at a time in your life, you'll have a tremendous impact on your health.
That's good. I'd like to leave in one parting thought and let people know that the most important thing that you can do is, again, changing your lifestyle. But I think the most important thing is to start with the basics, which is food is medicine. And if you start there, you can build, and grow all the other things we talked about this evening. If you're getting the right nourishment, then you can have the energy to exercise. You'll get better sleep. You'll be able to have better cognition. Food is medicine. That's what I really want to part with.
Thank you. Absolutely.
Okay, my friend, take care. And my friends, if you'd like to continue on listening to us and looking for us on social media at The Other Side of Medicine, we are on Facebook, we're on Instagram, we're on all the TikTok, we're on all the social media platforms, and we're here on this podcast every Friday, so you can catch beautiful presentations like we had this evening with Dr. Sharlin. Once again, Dr. Sharlin, thank you so much, and we'll take care, everybody.
Thank you.